We move to the next session. It's a very, very important session because we have to share 5 very interesting cases. This is one of the very important aspects of our community, to share our personal experience. It's something that is not able to find in a paper, in the book, but is our real life. So it's my pleasure to introduce the first speaker, Giuseppe Patti. Giuseppe, oh, thanks.
Good morning, everybody. Thanks, Sergio, for the presentation. And it's a great pleasure for me to share with you my most challenging cases. Thank you for the invitation. And this is a case I performed in my institution, Novara, in northern Italy, together with Sergio, I believe 2 years ago. The patient is a 77-year-old man with very high CHA2DS2-VASc score, with systemic hypertension, chronic renal failure, and atrial fibrillation from 2 years before the admission. The patient suffered from stroke 2 years before admission, complicated by hemorrhagic transformation, and after LAAC initiation, the patient suffered from an intracranial bleeding 2 months after edoxaban initiation. Echocardiography showed the normal left ventricular ejection fraction, a cauliflower-shaped left atrial appendage, spontaneous echo contrast in the left atrium, no thrombosis, and importantly, you can see that the patient had a membrane in the left atrium. The drainage from caval veins and from pulmonary veins was normal. The patients underwent a first attempt of LAAC closure, unsuccessful, and therefore we attempted the second time to close the appendage. You can see the echo images. You can appreciate the membrane dividing the left atrium in a superior part and in an inferior part. The membrane was incomplete with an open portion in the posterior part of the left atrium. CT imaging showing in anterior view and in lateral view the membrane. We performed the procedure with a septal puncture above the membrane at the site of the fossa ovalis. You can see the catheter introducing in the left atrium above the membrane. We used an Agilis 8.5 catheter after the puncture to access the left atrium above the membrane. You can see the angiography through the catheter in the superior part of the left atrium above the membrane. But with this position, we were not able to access directly the appendage. Therefore, we used an extreme flexion of the Agilis catheter. On the left side, you can see a rough scheme, handmade rough scheme of the trajectory of the catheter and of the wire along the posterior left atrial wall. and to positioning the wire in the left atrium. This is upper view, and this is on the left side, a lateral view. But at this time, we were not able to advance the Agilis catheter in front of the left anterior appendage. Therefore, we used a mother and child system using the Agilis catheter and a 6 French multipurpose catheter and a stiff wire inside the left ventricle to reinforce the system and stabilize the catheters. Then it was crucial to perform a counterwise rotation of the catheter to advance it forward and anterior in front of the left atrial appendage ostium inside the inferior part of the left atrium. This is the echo image with the catheter in front of the left atrial appendage ostium. We performed the angiography inferior to the membrane, below the membrane, and we selected the origin of the left atrial appendage. With the pigtail catheter, we directly accessed from the inferior part of the membrane in the left atrium. We accessed the appendage. With a stiff wire, we advanced the delivery sheath with the stiff wire looped into the appendage. Therefore, the procedure was smooth. We performed the measurement of the landing zone, 18 millimeters and 19 millimeters confirmed by echo. We selected the Amulet device 22 millimeters. We performed the device deployment and the release of the device. You can see these echo images, and this is the final release. Dear colleagues, in my opinion, key points of this clinical case is it's very important a comprehensive integrated left atrial assessment by cardiac CT and TE echo in patients complicated as we encountered in this case. It's important pre-procedural simulation of angiography projection based on CT reconstruction. We used a steerable catheter to facilitate the navigation within the left atrium and used a strong system with a mother and child catheters and a super stiff gyre to access the left atrial appendage occlusion. Thank you very much for your attention. In this slide are summarized the possible key questions, and although I don't know if we have time to address these issues.
Very nice. So we don't have that much time, but at least one question, and if not, I will do it. So do you have any question? Yeah, sorry.
I guess the diagnosis here is core triatriatum. Is that correctly understood, with the extra membrane and a fenestration in the membrane?
Yeah.
And secondly, it looked like your transseptal puncture was very high, but that was maybe because you wanted to go on the superior side of the membrane.
We first attempted to perform an inferior puncture, but we were not able to access the left atrium below the membrane. Yeah.
Yes, Eric, when I discussed the case with Giuseppe, the problem is that in this case, the membrane in the anterior position is between the superior, with the superior vena, pulmonary vein, and the inferior, in the inferior chamber where the LAAC. So, but toward the septum, was a continuous. Toward the septum, there was a hole close to the posterior vein. So we did exactly the opposite of what we do. Yeah. We go posterior, we enter in the hole, we go in we went in the second camera, in the inferior camera, and then we moving ahead. This is an extreme meanings of what is the pre-procedural planning.
So we have a last question from Professor Tondo.
Giuseppe, wonderful case. I mean, just learn a lot. Actually, even the surgical approach could be not really easy to do. Maybe someone, can raise the question, why don't you, think the lariat? But even with the lariat, even the actual, lariat probably could be just quite, difficult just to use it. So I think that is a great way just to do it.
Thank you, Giuseppe. This is the first time that I see a case like that, so congrats. Yeah, and we move to the next one. Dr. Luis Nombela from Hospital Clínic of Madrid will present another challenging case.
So thank you very much for the invitation. I don't know if it's the most challenging, but ones that I look for it. When I was preparing the case, we were doing this case like 2 months ago, and I say, okay, this might be a good case for the meeting with an LAAC 4, but very contractile appendage and asymmetrical shape of the ostium and the landing. But finally, we closed it directly with only one attempt, so I couldn't get this to present it. So then I review all the cases and check the time that we were doing. Most of them are combined procedures, and some that I had to change the device, but at the end I have these difficulties also to cannulate the appendage. So I choose this case, which was an 81-year-old female with anemia problems, a previous David procedure for an aortic stenosis, and also a TAVI that it was done in another centers. Unfortunately, we didn't have the pre-CT TAVI, so we screened the patient with the TE, and you can see here the morphology of the appendage, a chicken wing with an ostium with a landing zone of 16 by 17. So we were in between the 22 and the 25 amulet device. This was the beginning of the case. So we did the transseptal puncture in an inferior and posterior way. We thought by the 3D TE that it was good, that the septum, the trajectory was fine in that view. So we continued with the procedure, and we saw this smoking at the end of the appendage. So because of this, so we were thinking about this smoke at the end. So we changed to place a sentinel device, and then it was very when we advanced the sheath after placing the wire in the superior vena. Pulmonary vein, we were struggling to engage the appendage. We tried with pigtail, multipurpose GR, and we couldn't get insight into the appendage. So we moved the regular sheath to the steerable sheath, and after this, you can see here the wire in the superior vena cava, and then in the pulmonary vein, and the pigtail in the appendage, and at least we engaged the appendage. And when we were trying to advance the steerable sheath, at that time we had available this sheath. You can see that how we didn't have any support of the to advance it. So we placed 2 pigtails with the wire inside to give more support to the system. But again, also when we were trying to move it, it jumped, so we couldn't engage the appendage. So probably we need steering more at the base of this catheter or close to this transseptal puncture. So we step down and we move again. We leave a stiff wire in the appendage. We don't usually do this because we are changing the pulmonary vein, but in this case we change the steerable sheath with the regular amulet sheath, and we change that in the appendage. And finally, after 35 minutes of fluoro, we have the sheath in the appendage. So we thought that it was the amulet 22, it was going to be fine, but as you can see here, the coaxiality of our sheath was not good. We would like to have this coaxiality, and this is where we have measured for the 22. But our sheath was going that way, so we have a very leak in that zone. So we had to exchange to change the device for a 25, a bigger device, and to do a sandwich technique for this appendage. And well, finally we did the TAC test. The device was stable, and you will see when we release the device that the coaxiality of the catheter was not good. Finally, the disc covered this lower part of the appendage, and we succeed to close. We did a CT analysis for in the follow-up to see if the closure was good. As you can see here, the transseptal puncture was quite inferior, but it was not very coaxial with the axis of the appendage, which was that, and probably well, we couldn't get, or at least in that image, in the procedural planning, probably with a CT, we could have planned this procedure and get a better image of that. So I think that the embolic protection devices, in some cases, they can be useful, or at least to better feel for the operator if you have any complication. In this case, the steerable sheath helped to engage the LAAC distal, but then the softer standard sheath was useful to advance the delivery sheath into the LAAC closure. As I would mention also, how can preprocedural imaging better predict these cases? Probably CT better than TE, which is, for me, it's difficult to orientate or to get this coaxiality from the TE. And also I think that sometimes eyes can see or can guide you better to get a very inferior puncture than TE. I don't know if these are the open questions that I have for the discussion. Thank you very much.
Thank you, Luis. John Sarik.
Thank you for presenting this very difficult case. I think it is nice to see that, you know, the ELAACC score, one of the complexity parameters is low takeoff of the LAA, and that is what you had here in this case. And I think even your transseptal puncture here was very inferior and very nice, and I think it would be difficult to do it much differently, the transseptal puncture. So this is just a very difficult anatomy, and I'm sure that a steerable sheath could help and can help us in some of those cases. But nice to see the ELAACC score in action here.
Actually, Luis, can we go back to the presentation and calculate the ELAACC score in that appendage? That would be nice. I don't know, Laura, if you want to do it, the ELAACC, because I'm... So can we go back to the presentation and, you know, the echo? The other thing that I would like just to ask you, Luis, it's and also Marek, because it's related to the steerable catheters. My feeling is that in most of the cases, the steerability, of course, for fine-tuning, not, but when you really need it, it's because the transseptal, it's too high. And sometimes you cannot go lower because there's no fossa, and you don't want to force. So if you would like, to have, a steerable catheter that can turn, at the tip or can turn, of course, both would be the better. Or can turn at the level of the septum, what would you choose?
Well, for this case, that's what I was saying.
Not for this case, I mean for in general, because I think that if you get, just a low access, just with a curve, with the standard curve, you can,
Yeah, I think that if they can correct the transseptal puncture, I think maybe it would be better, but because then the tip you can correct it with your rotation. Yeah.
Okay, Laura, can you?
Yes, Xavi?
Yeah. Or
No, just a
LAAC.
question. When you have so much difficulty to enter the appendage, probably because of the low position, I wonder sometimes if a more anterior puncture is not more useful. And the second thing, do you check sometimes for the position? Because sometimes you think that you're inferior, but when you puncture, you're higher than what you think because it moved from any reason. Sometimes going for just a new transseptal puncture can make you gain a lot of time. Although in this case, probably it will have not.
Yeah, we thought about that, but because we reviewed the level of the puncture, then we saw that it was inferior, but maybe moving to more anterior. But also the appendage was quite anterior, and the chicken wing was also anterior. So.
But the good message is always to check, because you think you're inferior, but sometimes you're really higher than what you think.
No, regarding the LAAC classification, at least it will be a 2 because it's extremely bent. We don't know about contractility and also the low takeoff of the ostium. We don't have here the relation with the mitral, but probably it's also a low takeoff.
So between 2 and 3, eh?
Yeah.
Okay, so just so maybe the problem here it's what you were saying yesterday. It's the axis of the transseptal that here it's making things difficult.
I think that the point is that, in my personal experience, a good steerable catheter can't compensate and not correct transseptal puncture because the alignment is mainly due to the position of the transseptal puncture. So the message in our community should be, okay, take care and take your time for doing a correct position of the needle when you do the transseptal puncture. This is essential.
Okay, thank you, Luis.
Okay. Okay, we move to the next case. Laura? Okay. I suppose from the title I cannot close this LAA. This is a very complex case, I suppose.
Okay, so if I can have the slide. So this is a very recent case that we made with Xavi in the hospital, and we think that have several points that we can discuss. So this was a female, 64 years old, smoker, hypertension, HFpEF, persistent AF, and the indication was GI bleeding with chronic anemia. But let's move to the anatomy. That probably is the most important thing. This is the echo that we made in the cath lab, and for these patients we didn't have any previous planning, so it was the first look at the appendage. So we made the intervention with the patient with the mini TE. The patient was only with some anxiolysis. She was awake, and this is the images that we get. So I was thinking, okay, I think this appendage, it looks quite small, but I don't know if maybe there is any lobe or any bending that we are not seeing. Also with the 3D just on face, it looks quite small. So we just opened the 3D just to make the measurements and also to make some rotations just to be sure that it's not a chicken wing that is hiding any way. And in these first measurements, we found that the landing zone was 11 by 17, so extremely small, with a working depth of 8 millimeters. So I was telling Xavi, I don't know if maybe we can close or not this appendage, because it's a very difficult appendage. If we review the ELAACC score, it has a long pulmonary ridge, also high eccentricity. Just I go back, you can see there in the landing zone that was quite oval. We also have a short depth, working depth, and also was a hypercontractile appendage. So it's an ELAACC that in our experience is not so common. So this is a very difficult appendage. And what regarding devices that we can use for closing this appendage? So in our hospital, we have these 3 devices just available in the hospital. Because of that, sometimes we do the screening just in the table. And for the majority of patients, we can find a device that can fit our patient. But if we look here in all the tables, there was none of that devices that can fit this very small appendage. So we were thinking, okay, we need to stop here the intervention or not. But just because it was a very contractile appendage, we thought just go with the Transseptal and just have a look also to the pressure of the left atrium. So we went with the Transseptal, and we don't use 3D for Transseptal, but also was quite challenging just to obtain a direct view of the fossa to do the biplane for the standard Transseptal puncture. So we made also the Transseptal puncture with 3D, so it's inverted because short axis is on the left in the bottom and bicaval view is in the right, but we can have a very inferior Transseptal and quite posterior side of puncture. And also because this appendage was so uncommon, we decided to also do an angio just to be sure that there is no anything else. And you can see here that the appendage, it is what it is, what we were seeing in the 3D, so the correlation was quite good. It was only that very small lobe that was going up, but nothing else. So we make the measurements of the left atrial pressure. And we found that the left atrial pressure was 6 millimeters of mercury, so we just add, half a liter of serum, and the final left atrial pressure was 12 millimeters. So we repeat the measurements at that moment. And these are the measurements after the liquid infusion. And now we have a landing zone of 13 by 8 millimeters. So with this landing zone, we can fit there a small amulet of 16 device. So here is the implantation that also was not so easy. The Transseptal puncture, I will say that was quite good, but let's see if it's moving. Yes. You can see here that we just advanced the catheter inside the appendage. We were opening the lobe in the triangle conformation in the middle, but when we open it, you see there that in the bottom right, that is like a 135 degrees view of the appendage, but just coaxial to the 60 degrees, you can see there that the lobe was just turned. Okay, so we just try again, and here what we made is that Xavi was pushing a lot with the triangle conformation just to make room to accommodate the lobe. And you see here in the middle how the lobe is totally open and it's well sit inside the appendage, and there you can see that we were covering everything with this quite nicely. So because it was so contractile and we have this initial problem with the positioning, we just make a quite, I will say, aggressive tube test just to be sure that everything was fine. And here you can see in the echo how Xavi was pulling. So we decided, okay, we just release the device. And this is with the device release. And this is quite scary for me when I saw it because it was not attached, because it looks like it's floating, but you saw at the end of the imaging that suddenly it changed the position. This is with the cable attached. You see there at the end, plaf. So it changed from this scary position to a quite nice one, and the end was quite nice fitting of the device. This is the final result. And we were quite happy with the result in this quite challenging anatomy that we didn't know if was possible or not to close. So as case learnings, I will say that if we have a small hypercontractile left atrial appendage, the measurement of the left atrial pressure is super important. You see here how it changed to an appendage that was not possible to close to an appendage that was doable. And if you have a very short depth, I think it's quite interesting, the triangle position of the amulet, just to push and try to accommodate the device. And also, my concern in this case was the aggressive pull test that we made, that at the end I think that the appendage was invaginated and just accommodate at the end and just maintain this positioning. And that's it.
Yeah, I don't know if there is any question or comment.
Just before the session before, we talked about the amulet 2, that you should maybe oversize more to cover the anatomical. So I think this is a typical case when you have this prominent ridge like this, you don't see exactly where is the ostium. So really you have to rely on the circ. The circ is your marker, and the lobe must be placed distant to the circ, otherwise you get an embolization for sure. So that's what you did actually, but this is a typical case when you should focus more on securing the lobe somewhere in a good position than be obsessed about the ridge.
Well, but in this case, it was impossible to cover.
Even not to be true,
Yeah.
the safe position.
But it was not just for covering, it was just for safety because, you know, like the appendage was so extreme that I was concerned that it was not, you know, like just stable. Here, you know, of course, you know, Amulet 360 would have worked much better. But remember that the implantation depth was 8. So this feature about, you know, this device that you can push and you can create maybe 2 or 3 millimeters, those extra 3 millimeters by pushing, you know, the wall of the appendage, they can, you know, make the case possible or not. So with Amulet, it was with a triangle. Now with, you know, Amulet 360, it will be, you know, more, you know, but there's no distal pin, so I mean, it will be safer.
Xavi and Laura, can I ask you, because I have a problem, if there is such a small appendage, such much contracting so much, I have always a problem in my mind with the amulet with large hooks, because I always afraid that if the appendage is contracting so much, these, let's say, long hooks may perforate. Is it, am I thinking?
I think that, you know, like it might make sense, you know, again with the second generation, I hope that it doesn't, you know, like the risk is going to be minimized, but anyway, in this case, the pulmonary artery was just really, you know, not close. This is something that you can measure. If it's less than 1 millimeter, I mean, you might think of, but in this specific case, no problem at all. You know, the patient was discharged and, you know, we did the control 3 months later and nothing happened.
Just a question for both. If you had the CT scan for the planning, the situation.
Yeah, I think it's a good question because with the scanner, we don't know if the patient was, in theory they are not fasting, but maybe if we made the scan in summer, patient can be dehydrated and we can have this very small appendage and thinking that it's not possible to closure. The nice thing of using the 3D during the implantation is that you can check this landing zone and the measurement, and also you can recheck after the proper left atrial pressure. So you ensure exactly what is the real landing zone of this appendage. But I think that especially if you have a hypercontractile appendage, you always need to make the measurement of the left atrial pressure and again to make the measurements. Because,
what was the pressure in the left atrium at the time?
It was 6 and then was 12.
Yeah. Just last question, please.
So if you had a CT, don't you think you would have got the correct measurements? But when you give fluids and you make artificial measurements, you make it bigger, but when the left atrial pressure may go down, and then it might become smaller, isn't it?
Well, the thing is that a healthy appendage, that because of that I'm so concerned with the healthy patients, is that one of the properties is that it changes a lot the dimensions with the fluid, intravascular fluids of the patients. But the thing is that you need to be sure that the patient is euvolemic, and sometimes when they go to the cath lab, they are hypovolemic because they are fasting from the day before. And also you need to also have into account if it's very hot outside, in patients that came from a house or something like that. But at the end, if the appendage it's the size that we make the measurements with the euvolemic patient, I think it's not a problem if it reduces the volume inside the pressure inside the atrium, because at the end it's like you know, like a elastic thing that you know that the distension is that size. So I'm not concerned about that.
So what I'm saying is CT would have given you the correct size. I don't think CT will undersize it.
Yeah.
Okay, thanks, Laura. And we move to the next speaker. Fabian Niel-Dispatch will present us another challenging case of a giant LAA. Thanks.
Thank you very much. I have to change the title a bit. It's not multiple devices to close a giant LAA. It is just 2 devices to close an LAA. I show you 3 examples where 2 devices were necessary. I have to disclose that I did a few Watchman and lumbar and ultraseal cardiac cases. Then I actually switched to just amulet alone. Not because I didn't like the other ones, but because I felt that I can close all LAAs just with 1 device. But I have to disclose that maybe for some cases, lumbar users would say that their multiple lobes LAA, the lower ones where they have small lobes but huge discs, would have solved the problem. So I think that could be a solution in these cases. So first case is really giant LAA. This is a case that I did in my former institution, so I don't really have all the videos available. But you can see this patient had previous mitral valve surgery and had severe recurrent mitral regurgitation, and had this giant LAA. So here you can already see on the right-hand side that there is a small lobe next to the other lobe. So this was at the time of ACP, not amulet. I put in the biggest amulet, and then you can see there was a small lobe still uncovered where I put in a second device. I apologize that I don't have more images, but this is one indication for putting 2 devices if you have a giant LAA. I think there is also another indication where you have no neck and 2 lobes. And this is a case that was combined with a mitral clip. And you can see, first of all, that the puncture is not ideal. It's a high puncture. It's the puncture we used for the mitral clip. But if you manage to steer your catheter such that you get into the lobes, you can see that there are 2 lobes, one a bit further anterior and one more posterior. So I closed the one more posterior because the sheath was fitting in more easily. And I don't really recall why we stopped here and wanted to bring back the patient another time, which was a mistake, and I will come back to that later. But maybe it was also because of some people were saying that we used enough devices for the hospital in one setting, and they were not happy to use a second LAA occluder. I don't recall that, but unfortunately, the patient didn't want to come back for the second procedure, so this left atrial appendage was left as it was, and the patient is still an oral anticoagulation. Now, this is another case. It was done combined with TAVI, and you can see that it's again the same anatomy, no neck and double lobe LAA. So I always just go into the lobe where I get into first, and I put in an 18 millimeter amulet, and then I steered a bit more anterior. I got into the more posterior lobe and put in a 16 millimeter amulet, as you can see here, and this is how it looked at the end. So I think there are some procedural decisions you need to take if you put in more devices. The first decision is whether you want to do a one-stop shop or whether you want to do it staged. I showed you why you probably shouldn't stage the procedure, but I could see 2 reasons why you would stage it. Maybe there are 3 reasons. One is a financial reason if you have a big pressure from your hospital administration. The other reason would be if you're in doubt if the first device is really stable, you don't want to manipulate more in that area, you want to grow it in and you bring back the patient maybe a month later. Or in case of severe kidney disease, talking about a GFR 15 or something, and you already used enough contrast for the first device. The other procedural decision is, do you use one delivery system? That's my standard. I actually never did it differently. But if you want to use two delivery systems and deploy them either simultaneously or serially, you want to also need to decide, do you want to do two transseptal punctures or just one transseptal puncture? I really don't see an indication for this. I think it makes the procedure more complicated than needed. And then the last question would be, you have post-procedural anticoagulation. Would you just go with the same post-procedural anticoagulation, whether you have two devices in place or one device in place? You go for DAPT or you go for something else. I choose just to go for aspirin as with all the other devices. Well, this was a very short excursion to double device closure. I think it's something that you really need very rarely. And yeah, maybe people who have experience with lumbar, I would be keen to learn how they would have managed this case with the double lobe. Thank you.
Thank you, Fabian. We have a comment, question?
Just a comment. Just I refer to the first case. I think this is a really good example when the surgeon, didn't finish his work. I mean, just that there's a really big appendage. There's a cardiac surgery, and the stroke risk is really high. So cut off the appendage, and that's it.
I fully agree. I'm not so sure whether the stroke risk actually is high in such a huge appendage, whether it's higher or not. Somehow, if the appendage grows, it just becomes part of the left atrium. And it wasn't very trabeculated, but I 100% agree with you. It belongs cut out during the surgery.
Fabian, nice cases. Just quick comment about lumbar. I mean, as you know, there are the special lumbar, so you can have this with a small umbrella and a big disc. So in some cases, you can use this type of devices. And also we publish a short series with double lumbar. What is nice of lumbar is because you don't have the lobe, you have the umbrella. We try to use two devices at the same time, so simultaneous, two transseptal, so one to go posterior, another one to go anterior, and you are able to deploy the umbrella and know the disc. So before releasing the device, you are able to know if you have nice result or not. When you decide to do it sequentially, sometimes it's not so easy to get into that other lobe that you have not covered. So it's another possibility.
So you would still use two devices even if you use lumbar. So then there is really not a huge advantage. I was always concerned if you would use the one with the small lobe and the big disc, then you fully rely on the disc to close the second appendage, which the second lobe, it doesn't really seem so
yeah, of course, it depends on the anatomy. Probably the first case you saw, you are able to do it with the special lumbar. Probably the second that you saw is not so easy because they are far away. So in that case, probably you can try to use just one special device, and in case that you cannot do it, you do a second transseptal and you use two devices at the same time.
Okay. Laurent?
Thank you, Fabian. It's a nice approach for bilobar anatomy. The only thing we usually do is we keep the cable attached to the first one so that the disc is not out already, just to guarantee stability of the first one. And the second comment is in the last 10 cases we did, we had 30% pericarditis, so you need to be aware that the risk is probably a bit higher, and you just give them colchicine on the way.
Tom?
I just wanted to ask, in these, if you plan to do double devices, do you think there's an argument to be made for plug-style devices rather than lobe and disc devices to avoid interactions, or do you think it doesn't matter? And I mean, clearly you are successful with the disc designs. Do you worry about disc interaction, and do you care which one sits on top of which one, or do you just put them as they go?
Well, I have, let's say, maybe a more pragmatic approach to LAA closure than many people do. So this always is for me a surprise if I find it during the procedure. I don't do pre-procedural planning. So if I see this, then I always do it again in a pragmatic way. I just close the lobe that I get in first, that I think where you just land with your sheath, and then you approach the second lobe, which is actually never really a problem. It's really either you turn counterclock or clock, and then you're in the second lobe. So with regards to interaction of the two, I think there may be cases where this becomes a concern. I didn't encounter one so far. I think the main concern could be tissue overgrowth, right? And that's why I think maybe if the patient tolerates dual antiplatelets, then I would maybe put these patients on dual antiplatelets, whereas usually I would just use aspirin alone. But yeah.
Tom, do you have a question? No. Okay.
Okay. Thank you.
Thanks so much. We move to the last presentations. I invite Domenico Della Rocca, a large PDL requiring percutaneous closure.
So, good morning, ladies and gentlemen, and thank you for being here, and thank you to the scientific committee for the kind invitation. So I slightly changed the title of the presentation because I want to talk about a clinical entity that is very clinically relevant to me and irrespective of the size of the leak, and this is the fabric edge leak. So what is a fabric edge leak? It is a leak that results from a misalignment of the appendage of the device with the appendage. And so what happened, basically the frame of the device is not completely, that is exposed to the blood pool, is not completely covered by the fabric, and that's the result. So it's like a leak that even if it's like 2 or 3 millimeter involves like a big part of the device, and also why is clinically relevant? For two main reasons. First of all, because there is significant residual flow, but also turbulence. And second of all, because there is no coverage of the device, of a part of the device by the fabric, and so this device will never completely endothelialize. And so this is the case that I want to present. I want to thank Rodney Orton for this. I had the privilege of working with him for many years, and he is the brain and the hands of the majority of these cases. So this is like an 81-year-old male with hypertension, coronary artery disease and pulmonary hypertension who had a stroke and underwent a Watchman flex implantation, 24 millimeter flex implantation. And so this is the baseline. Sorry. I don't know why it's not. The second image doesn't. But so the device here is, as you can see already at baseline, the position of the device is not optimal, so probably it's a little bit oversized, this proximal. But then, there it is, okay. So we have already some shoulder on the mitral side, and then 45 days later, we have this device that already seems that it already seems a little bit rotated. And then on T, you can see that there is a fabric that is not completely covering the frame of the device with a significant leak. So here, like if you rely on the size of the leak, this leak is probably 2-3 millimeter, but then still, as we said, like the flow is significant inside the appendage, and there is no thrombus inside the appendage. So these are other images. And so here you can see at the base, we are approaching with a kind of multi-purpose catheter from the base of the appendage to enter inside between the fabric and the tissue and the appendage os. And then here, like first angio. So you can see like full, like completely empty appendage, maybe some thrombus here, and also with the turbulence that this leak creates, that these patients have high risk of thromboembolism. And then so we use coils and an Amplatzer vascular plug 12/9. And so this is the final result. So first of all, we took care of filling the appendage and beyond the device with coils. And then we placed the Amplatzer here. So first of all, we obliterated, we occluded the appendage, and then we took care of covering the fabric that was exposed to the blood pool, the fabric, the frame, the nitinol frame that was exposed to the blood pool in order to promote endothelialization in the long term. And this is the acute result. So you can see here the device. If we change the projection, the device that is on the side of the appendage. And this is the follow-up. So the appendage is occluded, there is no residual flow, and this is the device that we implanted. So this is like a little bit of a workflow that I put together in order to a kind of decision-making for the device leaks of different sizes. But then I want to underline this part that is, so the intermediate peri-device leaks, 3 to 5 millimeters, there are some sizes and some features that need further evaluation and eventually oral anticoagulation reinitiation. And this is another case that we had, and I would like to see if there is a chance to a discussion about this patient, because this is another patient that we had, and the leak is small, so the operator who did this device stopped anticoagulation, and the patient had a thromboembolic event 2 months later. Thank you.
Thank you, Domenico. To understand the mechanism of the PDL is essential for deciding for the right strategy. Question from the audience? Claudio.
Yes. Nice, Domenico. Maybe you can mention also for those who are not electrophysiologists the use of radiofrequency, just to close up some of the small leaks. This is something that it could be considered as just an option.
Yes. So like we published like a few years ago, especially for borderline appendages, borderline leaks, so 3 to 5 millimeters, in patients who were planned for an ablation after appendage closure, you can target the appendage side in order to promote like shrinkage of the tissue, like fibrotic shrinkage of the tissue, and then we saw that we are quite effective in closing like these borderline leaks also. So like if you have a patient with some borderline leak, like not talking about like uncovered lobes or other things, but like leaks, and the patient is planned for a redo procedure, I think it might be an option for that.
Yeah. One second, there is Lawrence and Fabian. Oh, Fabian.
Thank you very much. This was a brilliant case where you closed the leak. My question is, why did you put in the Amplatzer device? Wouldn't it be enough just to close the appendage with the coils, and thereby you clot the entire space, and it cannot provoke any further clotting there, or?
Yeah, so that's the tricky part of like the fabric edge leaks. So in this case, you see that you have the nitinol frame that is not covered by the fabric. So that part is never going to endothelialize. So you still have a certain degree of DRT because of that. And the reason why we decide to put an Amplatzer is just to promote DRT endothelialization of that part. So not only have an obliteration of the appendage, so we took part of the thromboembolic risk, but also put like an Amplatzer in order to promote endothelialization on that part of the appendage.
How many months after the first procedure was it done?
So in this case, we generally wait at least 6 months. But for this kind of appendages, there is like a very, very limited change. So I think, like especially if the patient has a thromboembolic event, we tend to intervene sooner. So in this case, I think was within the 6 months, but generally for other kind of leaks, we wait for at least 6 months, because there are also these longitudinal studies showing that there is a reduction of the leak in the long term.
And why the vascular plug 2? I mean, you need a way bigger sheath. Wouldn't it be wise to use the vascular plug 4, where you can go just with the diagnostic 4 French catheter? Wouldn't that be safer? Instead of wiggling a big sheath next to the device? I've no experience, I'm just asking.
But, so the first step was getting inside the device, because then that's the first part that you need to get to put coils there. If you just plug outside, and then there is still some risk that you are leaving something behind, and so there is still some risk of a flow. So with the rotation, you have a big part of the device that is exposed to the blood pool. So sometimes you don't cover enough of this fabric, of this frame. So you need to first get inside, put the coils to obliterate the appendage, and then. So that's why it was a step-by-step approach, and we were already there, and that's why we decided for a. Okay.
Okay, Jens-Erik.
Thank you. We also published a series of this fabric edge leak, and what we did the cases guided by ICE, had either just a transseptal sheet or a steerable sheet, and inside that 8 French coronary guide catheter. And that takes up to a 16 or 18 millimeter AVP2, and we only put the AVP2, the distal disc and the middle waist inside the intra-device space of the flex device, and then had the outer disc covering the entry to the sub-fabric or the edge. And in the series we had, we got complete closure just by using the AVP2 itself without using the coils. So I think it works pretty well.
Okay.
And thanks for showing the case, because I think it's one of the most frequent mechanisms for leak with the flex device. And again, also, you could say this is a small leak, 3 millimeters, but you see the flow washing in and out all the time, and it will never close. And I think it's something we need. We cannot leave those types of.
But I think, so I chose this leak because I remember last year when I did my presentation on leaks, we had this discussion on what would you definitely close, and I think this is the leak that I would definitely either not discontinue anticoagulation or close in case there is a possibility.
Yeah, Adel, last question, please.
That was my question. So, how do you state that it's a significant leak? Okay, I understand it's a very interesting mechanism, and I see it more and more when I retrospectively analyze some of my cases. But sometimes CT, even small, frame not covered can give LA patency, but difficult to quantify if it's significant or not. So, as Jens-Erik said, it can be relatively common. So the question is always where to go for it.
So, but then, if you look at the effect of the leak on the appendage, so if you see those appendages are completely empty. So, if you consider the effect of the leak on thrombus formation inside the appendage, sometimes you see that there is 3-4 millimeter, there is some thrombus, then it evolves, then you see that it's obliterated, and so that's worth waiting. But for this kind of leaks, you never see really thrombus formation, and you actually see, even with 2-3 millimeters, a significant flow with turbulence. And I think that's a way to say, okay, this is a failure of the occlusion somehow.
Domenico, I mean, it's easy to follow your ideas, and I agree, but do you have any data that a fabric edge leak is really more dangerous than a side gap leak?
We don't have data because it's something that, so we have this large series that should come out soon in JACI-P, and we have 300 appendage leak closures that we compare with patients with a closure at the baseline, and we have a higher risk of thromboembolic events. And unfortunately, like it's kind of a heterogeneous population. So we have fabric leaks, we have traditional, we have uncovered lobes. It's hard to correlate directly this with a possible risk. But if I see the effect on the appendage compared to other leaks, I say also like in terms of DRT, like you have a nitinol frame that is never going to endothelialize in that point. So potentially, based on what we know, there is a higher risk of DRT also in this patient. So maybe the thromboembolic event is not strictly related to the leak and the thrombus moved from the appendage, but rather some thrombus forming at the interface with the nitinol frame and the appendage. So like there are all the components that are associated with a higher risk of thromboembolic events in these patients.
Okay, please, quick question, quick answer, and we need to go to lunch, okay?
So just a quick question, these leaks, do you only notice after 45 days, or did you notice at the stage of the implant, or could you have done something differently on the day? Or is it because the device rotated, or is it?
That's I think like probably 90% of the leaks can be prevented at the time of implant. So I think the most important message here is like if something doesn't convince you, like try again. Even like try again with another transseptal, because one cause of this leak is that you have a high transseptal, and so you are rotated compared to the axis of the appendage, and so the inferior part is kind of like coming out. I think it's important in these that there is a nice collaboration with the imaging support, because this is something that you see going from 125 and above. Or like if you have eyes, take some time to do a transmitral view, that is where you see it. But then definitely if I see the implanted baseline, definitely that was a suboptimal implant.
Okay, thank you, Domenico. One thing that is important, before lunch, we're going to take, a photo group. Okay, so don't leave, just to check out. So stay, it's just very quick, 5 minutes in the lunch area. So we have lunch and we meet again, sharp at 2 p.m. Please. Thank you. Thank you to everyone.
Thank you, everyone.